Carpal tunnel syndrome is a pathology that involves the upper limbs, especially the hands and wrists, causing various often disabling disorders. It is a neuropathy, that is, a pathology that involves the compression of a nerve, in this case the median nerve, which manifests itself with symptoms of distorted or reduced sensitivity, tingling, burning, and numbness. In this video, we will see what are the causes, evolution, and available treatments. Hello and welcome to Med4Care. Today's topic is carpal tunnel syndrome. To understand what it is, let's see together how the carpal tunnel is made from an anatomical point of view and why this can lead to carpal tunnel syndrome. The median nerve runs through the arm and forearm and finally reaches the hand, innervating the thumb, index, middle, and part of the ring finger. This nerve also supplies innervation to the various muscles of the thenar eminence, which is the most important muscle part of the palm of the hand, located between the base of the thumb and the wrist. When it crosses the inside of the hand, it crosses the so-called carpal canal, more commonly known as the carpal tunnel. The carpal tunnel is an osteofibrous canal formed by the carpal bones, which serve as the floor of the canal, and the transverse carpal ligament, which forms the roof of the canal. In addition to the median nerve, this canal also contains the muscles and flexor tendons of the hand with their sheaths and some blood vessels. When the carpal tunnel narrows, for example due to a dislocation of the carpal bones, the median nerve can be compressed, resulting in pain, which is typical of this syndrome. An increase in the contents of the tunnel itself, such as a tendinopathy or a neoplasm, can also produce compression of the median nerve. The result of this compression often leads to tingling and numbness in the hand and wrist, and in some cases the pain and irritation can extend to the forearm and upper arm. We have seen that carpal tunnel syndrome is caused by mechanical compression of the median nerve within the carpal tunnel. The causes are due to the increase in the total volume present in the tunnel, which consequently increases the pressure in the structures contained, including the median nerve. Among the most common causes of this compression are fracture of the carpal bones, fracture of the distal radius, luxation of the lunate bone, abnormal thickening of the transverse carpal ligament, degenerative diseases of the carpus. Similarly, an increase in the contents of the carpal canal can also compress the median nerve from within. Some clinical conditions causing this increase in the canal contents are acute tendinopathies, chronic tendinopathies, inflammatory pathologies of the flexor tendons, cystic tendon neoformation, congenital deformations of tendons and flexor muscles, tendon neoplasms, neoplasms of the synovial capsules, outcomes of previous surgical interventions on the canal with significant scarring, median nerve neuroma. Finally, there are some pathologies or hereditary conditions that can be at the origin of carpal tunnel syndrome or can be a risk factor. These are conditions that affect the whole body in which, for various reasons, the amount of water retention in the tissues, and consequently also the amount of space occupied by the structures contained in the carpal tunnel. Let's talk about gout, pregnancy, especially from the 3rd month onwards, amyloidosis, frequent in dialysis patients with chronic renal failure, rheumatoid arthritis, obesity, diabetes mellitus, hypothyroidism. It should be noted that some professions, in which the hand and wrist move repetitively, tend to facilitate the appearance of this syndrome, such as tailors, musicians, hairdressers, and typists. Women between 40 and 60 years old, mainly in developed countries. The most frequent symptoms of this pathology are mainly the alteration of the skin sensitivity of the areas innervated by the median nerve, therefore in the first 3 fingers of the hand, and part of the ring finger and of the wrist. This impairment manifests itself as distorted sensation, or paresthesia, reduced sensation, or hypoesthesia, tingling, burning, or numbness. In many cases, these symptoms are more pronounced during the night hours, sometimes forcing the sufferer to shake his hand during sleep due to the loss of sensitivity. During the day, the discomfort is generally minor, but it can awaken in the event of repetitive hand movements during normal daily activities. In case the compression of the median nerve is very strong, then the symptoms can worsen and cause constant discomfort and numbness throughout the day. Carpal tunnel syndrome tends to get worse over time, so it is essential to act promptly in diagnosing and setting up therapy. The clinical picture of this syndrome often evolves in 3 stages. The first phase, called painful irritative phase, is characterized by a sort of burning, tingling, and temporary loss of sensitivity in the first 3 fingers of the hand and wrist, especially during the night. The second phase, the paresthesia painful phase, is characterized by the presence of pain even during the day. Moreover, the night is punctuated by frequent micro-awakenings due to paresthesia. Such disturbed and fragmented sleep can lead to asthenia, difficulty concentrating, and drowsiness. Finally, the most severe phase of the carpal tunnel syndrome is the atrophic paralytic phase, where there is the impossibility of performing certain movements with the hand due to the total compression of the median nerve and the consequent altered innervation of the thenar muscles, i.e., those side of the thumb on the side of the palm of the hand. This phase is often accompanied by hypertrophy of the same area, i.e., the gradual loss of muscle volume and consequently of the strength of those same hand muscles. The evaluation of carpal tunnel syndrome first of all involves an accurate objective examination that considers in the right way the symptoms reported by the patient during the anamnesis. Subsequently, the skin sensitivity and the muscular strength of the hand are evaluated. Then we proceed with provocative clinical tests and, finally, with instrumental tests. During the objective examination of the hand, the doctor tests the skin sensitivity of the first 3 fingers and the wrist, evaluating how the sensitivity is reported by the patient, whether in a distorted or decreased way, or completely abolished. Subsequently, the strength of the muscles of the thenar eminence is evaluated by inviting the patient to oppose the thumb to the other fingers and considering the strength of this movement. Visually, the hand may appear normal or, in the case of acute tendinopathy or other inflammation, there may be some signs of inflammation such as edema and localized redness. The hypertrophy of the thenar area, therefore of the area between the thumb and the wrist, is visible in the last phase of carpal tunnel syndrome. Finally, hand percussion in the areas innervated by the median nerve can cause pain. Once the first part of the physical examination has been completed, the orthopedic surgeon subjects the patient to provocative clinical tests. Particularly, Tinel-Hoffman test, in which the doctor taps lightly on the median nerve site. If this action corresponds to tingling or discomfort in the first 3 fingers, then the test is successful. Phelan test, where wrist flexion, compressing the nerve, can cause paresthesia and tingling in the first 3 fingers. Pneumatic cuff test, through the cuff of the pneumatic cuff, paresthesias are caused in the innervation area of the median nerve. Once the visit is completed, the doctor prescribes instrumental tests that are divided between electrophysiological tests and tests that provide images. Electromyography, EMG. To highlight the state of muscular suffering at rest and during light and intense efforts. Electroneurography, which evaluates the speed of nerve impulses from the median nerve. Somatosensory evoked response, SSER, test, which studies the responses of the central nervous system to a sensory stimulus. Imaging examinations include X-ray of the carpal tunnel to examine any trauma suffered and highlight a possible narrowing. Ultrasound of the contents of the carpal tunnel, which allows a dynamic analysis of the contents of the canal and the movements within it. Nuclear magnetic resonance, NMR, which can very accurately identify the structures based on their consistency. Once diagnosed, carpal tunnel syndrome can be treated with more conservative medical treatment or more definitive surgical treatment. The conservative medical approach consists of various approaches including wrist splint and immobilization, pharmacological therapy with non-steroidal anti-inflammatory drugs, pharmacological therapy with corticosteroids. Other conservative therapies that can be adopted are iontophoresis, anti-inflammatory electrotherapy, and ultrasound application. If, on the other hand, surgical treatment is chosen, the doctor can opt for Median nerve neurolysis, where doctors incise the palm of the hand and divide the roof of the carpal tunnel, increasing the size of the tunnel, thereby decompressing the median nerve. Endoscopic carpal tunnel release. Using a small incision and small incisions, the doctor uses a miniature camera, an endoscope, to see inside the hand and wrist. A special scalpel is used to divide the transverse carpal ligament, similar to the neurolysis procedure. The two techniques have different indications, and it is the surgeon's task to evaluate which of the two surgical approaches is more appropriate for the individual patient. Following surgery, it will be necessary to keep an elastic compression bandage on the hand and wrist for at least 7 days, gradually resuming use of the hand starting from the second week after surgery. After this phase, to allow for full recovery, active and passive hand mobilization exercises will be carried out, followed by muscle strengthening techniques. In the majority of patients, carpal tunnel syndrome tends to get worse over time, so early diagnosis and treatment are essential to avoid serious consequences. If it is treated promptly, it is possible to resort to non-surgical medical therapies that decompress the trapped median nerve, restoring full functionality to the hand. We have now reached the end of today's video. We hope you enjoyed it. If you found it useful, support us with a nice like, subscribe to the channel, and click on the bell to be notified every time a new Med4Care video comes out. See you soon.